I spent 31 years in emergency medicine, Level 1 Trauma Center in Central Texas. I want to be clear about something before I start. I'm not a man who believes in things he can't measure. I've pronounced over 600 patients dead in my career. I've held beating hearts in my hands during thoracotomies and felt them stop. Death to me was always a clinical event, a series of measurable cessations. Electrical activity stops. Perfusion ceases. Chemistry begins its predictable decay. I retired in November of 2019, 8 months earlier than I'd planned, and the reason I retired early, that's what I need to tell you about. March 14th, 2019. I was the attending on overnight. It was a Thursday, which meant the trauma bay had been quiet until it wasn't. EMS called in a patch at 2:41. 68-year-old male, unrestrained driver, single vehicle rollover on Route 183. Prolonged extrication, approximately 22 minutes. Field GCS of 3, intubated on scene. They rolled him in at 2:47. Henry Callister. I remember the name because his driver's license was intact, sitting in a clear bag on the stretcher rail, and I looked at it while the medics gave report. 68 years old, organ donor. His vitals on arrival were what you'd expect from someone who'd spent 20 minutes pinned in a crushed sedan. Blood pressure 62 over palp. Heart rate 38, sinus bradycardia on the monitor, but already showing PEA morphology. Electrical activity with no corresponding pulse. Bilateral pupils fixed and dilated at 6 millimeters. We went to work. This is what we do. You don't think about the person, you think about the physiology. Bilateral chest tubes went in within 90 seconds of arrival. Left thoracostomy drained 400 milliliters of frank blood immediately. Right side 250. Fast exam was positive in Morrison's pouch and the splenorenal recess. I activated the massive transfusion protocol before the second unit of O-negative was even hung. Epinephrine, 1 milligram IV push every 3 minutes. We pushed 12 rounds. Bicarb at the 20-minute mark when the blood gas came back. pH 6.91, base excess negative 19. We gave 2 amps of calcium chloride for the empiric hyperkalemia. We cardioverted twice when the rhythm briefly showed something that might have been VFib, though in retrospect it was probably artifact from the chest compressions. 47 minutes. That's how long we worked. At 3:34 a.m., I looked at the monitor, looked at the team, and called it. Time of death, 3:34. I said it exactly the way I'd said it hundreds of times before. The charge nurse documented it. Respiratory pulled the vent, the techs cleaned up the bay. I filled out the death certificate worksheet. Cause of death, blunt traumatic injuries due to motor vehicle collision. Manner, accident. I checked the boxes. I signed my name. At 3:51, one of the residents, Dr. Patel, a second year, drew the post-mortem labs. This is standard procedure for trauma deaths that go to the medical examiner. You draw a rainbow, a full set of tubes, and send it off. Chemistry, CBC, coag panel, blood type, and screen. It's documentation, that's all. Nobody ever looks at postmortem labs expecting surprises. The surprise already happened. The patient is dead. I went to the break room, poured coffee, ate half a granola bar, started my chart note. The department was quiet. The board showed 3 patients. A laceration in room 7, an asthma exacerbation in 12, a psych hold waiting for placement in the secure bay. Routine. At 4:23 the lab called. The tech's name was Martin. He'd been working the overnight chemistry bench for 9 years. He was not a person who called about results unless something was genuinely wrong with a specimen. Hemolyzed samples, mislabeled tubes, insufficient quantity, that kind of thing. Martin said the results were ready on the Callister post-mortem, but he wanted to verify the time of collection and confirm the patient was in fact deceased. I told him yes. Pronounced at 3:34. Blood drawn at 3:51. The patient was dead. He said okay. Then he was quiet for about 5 seconds. "Dr. Webb," he said, "could you come look at these?" I didn't think much of it then. I figured it was a labeling issue. Maybe the tubes got mixed up with another patient's blood. It happens. Rarely, but it happens. I told him I'd pull them up on the computer. I wish I'd just left it there. I sat down at the nursing station and pulled up the results on the EMR. Postmortem chemistry panel. Collected 351. Received in lab 402. Resulted 423. Here's what postmortem blood looks like, clinically. Potassium rises, usually fast, because dead cells lyse and dump their intracellular contents. Glucose drops because there's no hepatic output, no glycogenolysis, no metabolism. Lactate rises because there's no circulation to clear it, no functioning liver to process it through the Cori cycle. These are predictable, measurable changes. I've seen thousands of postmortem panels. They all look the same way. Henry Callister's did not. Glucose, 142 milligrams per. His last antemortem glucose, drawn during the resuscitation at 312, had been 67. Now, 39 minutes after death, it was 142. More than double, in a body with no functioning liver, no circulating insulin, no perfusion. Lactate, 8.7 millimole. That was actually consistent. High lactate in a trauma arrest, sure. But the trajectory was wrong. His antemortem lactate at 312 had been 14.2. It was clearing. In a dead man, potassium 4.8 milliamps per eel. This one almost made me laugh. 4.8, that's normal. That's a normal potassium in a living, healthy adult. 39 minutes after cardiac death, potassium should be climbing toward 8, maybe 10. Cell membranes lose integrity. It's basic physiology. It's physics. I called Martin back. I told him to rerun the samples. He said he already had. Twice. Same results. I ordered a redraw. I went down to the trauma bay myself because I needed to see the body. I needed to confirm what I already knew, that Henry Callister was dead. He was dead. Body temperature 35.1 degrees Celsius and dropping. No pulse at the carotid, femoral, or radial. Pupils fixed and dilated. The early signs of rigor were beginning in the small muscles of his hands and jaw. Livor mortis was establishing in the dependent areas. This was a dead human body displaying the expected physical changes of death. I drew the blood myself, both arms, labeled the tubes with my own handwriting, walked them down to the lab personally, watched Martin run them at 452, glucose 168, lactate 1.2, potassium 4.6. The glucose was still rising. The lactate had dropped from 8.7 to 1.2 in 1 hour. In a body with no heartbeat, no liver function, no metabolic machinery, the blood chemistry of Henry Callister was behaving as though he was a living patient recovering from a critical illness, responding to treatment he wasn't receiving. I stood there in the lab, watching Martin's face. He didn't say anything. He just pointed to the printer as the reference ranges printed out, every single value falling within normal limits except the glucose, which was elevated in the way you'd see after a dextrose infusion, which no one had given because the patient was dead. At 5:15, I drew a third set. I couldn't not draw it. You understand, I'm a clinician. When data doesn't make sense, you repeat the measurement. That's the whole foundation. Reproduce and verify. Glucose 189, lactate 0.8, potassium 4.4, hemoglobin 14.1. It had been 6.2 during the resuscitation after he'd bled out half his volume. The hemoglobin should not have changed. We'd stopped the transfusion when we called the code. There was no new blood going in, but his hemoglobin had more than doubled in a corpse. That's when the charge nurse came in. She said the blood bank had called about a cross-match discrepancy on the Callister case. On admission, his type and screen had come back A positive, standard result used for the MTP cross-match. But the post-mortem type and screen, drawn from the same veins in the same body, was coming back O negative. I asked her to repeat that. She did. The blood in Henry Callister's veins 90 minutes after death was no longer his blood type. I sat down in the hallway outside the lab, on the floor actually, back against the wall. Something I hadn't done since residency. I told Martin to send the third set to the reference laboratory at University Hospital for independent verification. The results came back at 9:40 that morning. They matched ours exactly. I didn't document any of this. In 31 years, I had no framework for what I was seeing. If I charted impossible lab values on a deceased patient, the most likely outcome was a contamination investigation, questions about my competence, and paperwork that would lead nowhere, because the data was real. I'd drawn the blood myself, watched it run, the data was real, and it was impossible. 3 weeks later, I went to the Regional Trauma Case Conference in Austin. I almost didn't go. I'd been sleeping badly, not because of nightmares, nothing dramatic like that, just a low-grade insomnia that came from a question I couldn't stop turning over. A clinical question without a clinical answer. The conference was routine. Blunt trauma outcomes, penetrating injury algorithms, the usual. I sat in the back row and half listened. The last presenter was a trauma fellow from St. David's Medical Center, a hospital about 187 miles south of us. She was presenting a case she called unexplained acute metabolic crisis in a young patient with no identifiable etiology. 23-year-old female, no medical history, no medications, found by her roommate at 03:40 a.m. on March 15th, 6 minutes after I pronounced Callister, unresponsive on her bathroom floor. Field glucose, 41 milligrams per hours. They pushed D50, 25 grams IV. By arrival at St. David's at 4:08, her glucose had dropped to 34. Another amp of D50, D10 drip at 150 milliliters per hour. It didn't matter. 4:30, glucose 28. 4:52, glucose 22. Seizing. They intubated, pushed lorazepam 2 milligrams. Her lactate on arrival, 1.1, normal. By 4:30, it was 6.8. By 5:15, 12.4, no source, CT clean, no sepsis, tox negative. Profound metabolic failure with no identifiable etiology. I was gripping the armrest of my chair because I recognized the numbers, not vaguely, not in a general sense. I recognized the specific values. Her glucose at 4:52 was 22. Callister's post-mortem glucose at 4:52 was 168. Add them together, 190. His antemortem baseline glucose had been 94, and her normal fasting glucose from a physical 4 months prior was 96. The sum of their simultaneous values was holding constant, hovering around 190, the approximate total of 2 normal glucose values. She was losing what he was gaining. I found the presenter afterward, asked, trying to keep my voice clinical, about the patient's blood type. She said O negative, then paused. Actually, her prior records showed A positive, but every sample that night typed O negative. I went home, pulled the data, Callister's post-mortem labs and her case values, spreadsheet, time on x-axis, chemistry on y-axis, 2 lines per analyte. The lines were perfect mirrors. Every value that improved in Callister's corpse, glucose rising, lactate clearing, potassium normalizing, hemoglobin climbing, was matched by the exact inverse deterioration in the woman at St. David's. Point for point, minute for minute. I ran the Pearson correlation coefficient on the glucose curves alone, negative 0.997. For context, negative 1.0 is a perfect inverse relationship. In clinical research, anything above 0.8 is strong. Negative 0.997 isn't coincidence. It's not artifact. It's a mathematical relationship between biological data from 2 humans 187 miles apart who had never met, shared no genetics, no environmental exposure, no common factor, except that one died at the exact moment the other started dying. The woman survived, 11 days in the ICU. Discharged with permanent glucose dysregulation. Her endocrine system never recovered. She wears a continuous glucose monitor now, She will for life. Callister's body went to the ME at 6:30. I drew one final set at 6. His chemistry was perfect. Every value normal. Textbook healthy adult. In a man dead 2 hours and 26 minutes. Skull fractured in 3 places, spleen in pieces. The autopsy report, blunt force traumatic injuries. Blood chemistry, unremarkable. As if none of it happened. I didn't publish, I didn't report it. What journal accepts a case report claiming a dead man's chemistry siphoned metabolic function from a living woman 187 miles away? They'd audit the lab, audit me, find clean data and verified samples, and still close the investigation. Because the conclusion was impossible. I retired 8 months later. Told my wife it was the knees. 31 years on Trauma Bay concrete. She believed me. But in those last months, I pulled post-mortem chemistry on every trauma death. 17 patients. 3 times, the numbers did something they shouldn't. Glucose rising, lactate clearing, chemistry trending normal in bodies that were cold and still. I never found the corresponding patients. Never looked. Because I understood the data would be there. And finding it would confirm only that something measurable, something reproducible, continues in the space between a living body and a dead one that we were never trained to look for. And I don't think we